Sorry. Let's see. Okay. This is my video number 3 for the ARDs protocol. My name is Abby Redwine. And the first thing we're going to talk about is anatomical alterations of the lungs dealing with ARDs. So you're going to have alveolar consolidation, which was shown in one of my previous videos in the X-ray, intraalveolar hyaline membrane. So that's going to be a surfactant deficiency. Again, pulmonary surfactant deficiency, and also atelectasis, because the lungs are going to become, with the fluid overload, they're going to close, which causes atelectasis. And because it's harder to oxygenate and ventilate, they can't get those big deep breaths open to pop those alveolar open, and it doesn't help with the atelectasis. Etiology and epidemiology, there you go, is about 10 to 15% of all ICU patients are ARDS patients, and about 25% of them are mechanically ventilated. ARDS will usually appear 6 to 72 hours after an incident, and it gets worse very quickly. So say like someone had like a cold or traumatic event, like a trauma, car wreck, or fell up a ladder. Next thing you know, your ARDS is like, hey, here I am to worsen things. And the patient's going to present with dyspnea, cyanosis, bilateral crackles, hurt in the lungs, tachypnea, tachycardia, diaphoresis, and the use of accessory muscles on inspiration. So some diagnosis criteria is going to be the Berlin definition, which is timing within 1 week of a known clinical insult or new or worsening respiratory symptom. Cardiogenic pulmonary edema also presents like ARDS, and that needs to be ruled out. It is difficult because they both have the bilateral infiltrates, air bronchograms on X-ray, so it's a little bit harder. They'll have ARDS patients will have acute hypoxemia, respiratory failure with bilateral infiltrates is what ARDS is going to present like, and that's one of the main telltale signs that you can rule out between pulmonary edema and ARDS. You can find the severity of ARDS by using the PF ratio. So that's going to be your P(a)O2 divided by FiO2 that they're on. So, and then your mild cases is going to be greater than 200 but less than 300. For moderate, it's going to be greater than 100 but less than 200, and for severe, it's going to be less than 100. So some diagnosis criteria continued. Here you're going to have, I show some X-rays. The first picture we see is an X-ray. The first one is of ARDS. So you see the air bronchograms, consolidation, and then the one on the right side is a normal chest X-ray. And then here on the bottom is going to be a CT scan. And you can, again, the first one is going to be your ARDS patient, and the second is a normal. And you can easily see that the consolidation is there. So what we're going to talk about is the 5 Ps. It's going to be perfusion, positioning, protective lung ventilation protocol, protocol weaning, and preventing complications. And yes. So some general management of ARDS is you're going to take a corticosteroid, oxygen therapy if needed, and then definitely lung expansion therapy. You want to get that lung expansion therapy to get in there, get to the bottom of the lungs where there's the most pooling and be able to pop those alveoli open so it causes less atelectasis. You can help improve oxygenation and hopefully try to stay on the healthier side. So some clinical manifestations, your vital signs, again, it's going to be tachypnea, cyanosis, substernal retractions, and a dull percussion note heard over the lungs. Your ABG for a moderate ARDs, you're going to have an increased pH, decreased PaCO2, a normal or decreased bicarb, and a low SaO2 or low PaO2. Now for severe ARDs, it's a little bit opposite. So it's going to be a decrease in pH, increase in your PaCO2, and an increase or normal bicarb, and then a decrease in your SaO2 or your PaO2. And for an X-ray, you will see opacities diffusely throughout the lungs. And then in the lungs for X-rays as well, for more severe ARDs, the denser the lungs become, the wider the X-ray will show.